Hello everyone. The topic of today's discussion is hip and knee dislocations. Myself, Dr. Rahil Jivani. So this question can come as a long answer question or a short answer question in your final exams. And a dislocation case, as per se, doesn't come as a case in a practical examination. So we'll cover the topic from theoretical perspective. So first, let us see for some definitions. Primarily, there can be a dislocation or a subluxation. So what's the difference between a dislocation and subluxation? In a dislocation, there is no contact between the articular surfaces of the joint. A joint is dislocated when its intra-articular surfaces are completely displaced one from the other, so that all contact between them is lost. As you can see in the figure here, there is absolutely no contact between the surfaces. And a subluxation is said to occur when its articular surfaces are only partially displaced and retain some contact between them. As you can see here, the articular surface has some contact and this part is not contact. Okay. We can classify joint dislocations as congenital or acquired. Dislocation subluxation may be classified on the basis of etiology into congenital or acquired. Congenital dislocation is a condition where a joint is dislocated at birth. For example, congenital dislocation of hip, which is also known as developmental dysplasia of hip. An acquired dislocation may occur at any age. It may be either traumatic or pathological of the bone. So acute traumatic dislocation is an episode of dislocation where the force of injury is the main contributing factor. Example, shoulder dislocations. In old unreduced dislocations, a traumatic dislocation not reduced may present as an old unreduced dislocation. For example, old posterior dislocations of the hip. For recurrent dislocations, if in some joints proper healing does not occur after the first dislocation, it can result in weakness of the supporting structures of the joint, so that the joint dislocates repeatedly, often with trivial trauma. Recurrent dislocation of the shoulder and patella are common. Coming to fracture dislocations, it can happen when a dislocation is associated with a fracture of one or both of the articulating bones. It is called as fracture dislocation. A dislocation of the hip, often associated with a fracture of the lip of the acetabulum, is its example. Coming to pathological dislocation, articular surfaces forming a joint may be destroyed by an infective or a neoplastic process, or the ligaments may be damaged due to some disease. This results in dislocation or subluxation of the joint without any trauma. Example can be dislocation of the hip in septic arthritis. So now coming to the main topic, that is dislocation of the hip joint. So first starting with the anatomy of the hip joint. A hip joint is formed between the head of the femur here and with the cup of the acetabulum. These two bones forms the hip joint and it is stabilized with the help of ball and socket structure and ligaments and muscles. So it's a type of synovial joint of ball and socket variety. Femoral head is slightly asymmetric, forms two-thirds of a spear. And acetabulum is inverted U-shaped articular surface. And this is the ligamentum teres, and it has an artery to the femoral head that passes through the middle of the acetabulum. So blood supply to the femoral head is very important because any damage to the blood supply can result in the avascular necrosis of the hip joint, which is a very common condition and very debilitating. So coming on to the first blood supply, that is artery of ligamentum teres. As we have seen the previous slide, this is ligamentum teres. So artery of ligamentum teres comes from the acetabulum and goes to the head of the femur. This artery is mainly important in children because before the epiphyseal fusion, the artery of ligamentum teres is one of the main supply of the femoral head. and its contribution decreases with the age and is probably insignificant in elderly patients. The other blood supply is the ascending cervical branches. These are the ascending cervical branches. So this arises from the circumflex femoral artery. This is the circumflex femoral artery. It gives off two branches, medial and lateral. So arises from the ring at the base of the neck. Ring is formed by branches of the medial and lateral circumflex femoral arteries. This part. This penetrates the capsule near its femoral attachment and ascends along the neck. These are the cervical vessels. This perforates bone just distal to the articular cartilage. This is the articular cartilage. So these vessels are perforating the bone at this point, and this is highly susceptible to injury with any type of hip dislocation. Whenever a hip dislocation occurs, the capsule puts tension on this vessel, and this vessels get strangulated and can result in loss of blood supply to the femoral head, resulting into a vascular necrosis of the hip joint. One more important structure is the sciatic nerve. Sciatic nerve arises from the lumbosacral plexus. This part will be the lumbosacral plexus. It is composed of the nerve root arising from L4, L5, S1, S2 and S3. These five nerve roots combines and forms the sciatic nerve, and it enters from here. It has two main components, peroneal and tibial components. Differentiate early, sometimes as proximal as in the pelvis. It passes posterior to the posterior wall of the acetabulum, generally passes inferior to the piriformis muscle in this part, but occasionally the piriformis will split the peroneal and the tibial components. So any injury at this level will damage both the peroneal and the tibial component, resulting in complete immobility of the lower limb. And if only the peroneal component is involved, then it will result in the classical foot drop. Now coming to the classification of the hip dislocations. Depending on the position of the head of the femur with acetabulum, hip dislocations are classified into three types. It can be a posterior dislocation, can be anterior dislocation, it can be central dislocation. In posterior dislocation, the head of the femur will move posterior to the acetabulum. In anterior dislocation, it will move anterior to the acetabulum. And in central dislocation, it will fracture the roof of the acetabulum and move into the peroneal cavity. So the most commonest type is the posterior dislocation, and is seen in 80 to 90% of the cases. Anterior dislocation is seen in 10 to 15% of the patients, and in central dislocation is relatively rare, but it is the most difficult type to treat because it damages the acetabulum in the roof part, which is very difficult to reconstruct. So the patient will have arthritis more in these cases. Coming to the mechanism of the injury, thus coming to posterior dislocation. The posterior dislocation is commonly occurring in a road traffic accident. It is classically known as a dashboard injury. This is the dashboard of the car. When you have a road traffic accident, the knee in a flex position strikes the dashboard of the car, and we can have a posterior dislocation. It is usually due to backward directed force along the line of the femur in a flexed hip. If the femur is more adducted at the time of impact, pure dislocation results, and if the femur is slightly abducted, it can result in a fracture dislocation. The fracture part can be head of the femur or the acetabulum. In anterior dislocation, it occurs when the mechanism of injury is occurring in a hyperextension force. It extends the hip joint with hip in extreme abduction and external rotation. So classification of hip dislocation. The classical classification is the Thomas and Epstein classification of hip dislocation. It classifies hip dislocations on the basis of dislocation with or without the fracture of head of the femur or the acetabulum. In type 1, there is only dislocation of the femoral head and there is no fracture. Even if there is a fracture, it is a very small fragment. In, as you can see here, there is only dislocation and no fracture. In type 2 dislocation, dislocation is associated with a big chunk of the posterior wall of the acetabulum. This is the fractured fragment. In type 3 dislocation, the dislocation is associated with comminuted fracture of the roof of the acetabulum or the posterior wall of the acetabulum. You can see there are more than 2 to 3 parts, which is known as comminution of the fracture fragments. In type 4 dislocation, we have dislocation with fracture of the acetabular floor. This is the acetabular floor, and it is fractured along with the dislocation. In type 5, we have dislocation with the fracture of the femoral head. You can see acetabulum is conserved, but the head of the femur is fractured. There is one more classification known as AO or OTA classification. It's a very standard classification, but it is mostly used to allow for comparison of patients from different study and for reporting of data. There are three types according to it: 30D10, 30D10, that is anterior hip dislocation, 30D11, posterior hip dislocation, and 30D30, that is obturator hip dislocation. It has more significance for recording of the data. Coming to the clinical features of hip dislocation. Similarly, in posterior hip dislocation, it is known as a FADIR, F-A-D-I-R. F for flexion, AD for adducted, and IR for internally rotated. In anterior dislocation, it is Faber, F for flexed, A for abducted, and ER for externally rotated. In this case, there may be a lengthening present, and on palpation, head may be felt over the pubic bone or in the perineum on the anterior part. And on movement, there will be painful limitation of the movement in all the planes. In anterior dislocation of the hip, there can be damage to the femoral vessels and nerves. So we have to look for distal neurovascular status of the affected limb. Coming to the investigations, investigations will be mainly a radiograph, that is an X-ray, a CT scan, that is a computed tomographic scan, or MRI scan, that is magnetic resonance image. X-ray will be an anteroposterior view of the pelvis. Femoral head will not be centered in the acetabulum. Femoral head will appear larger than the acetabulum if it's anterior dislocation, and it will appear smaller if it's a posterior dislocation. It usually provides enough information to proceed with close reduction. You can also ask for judate views. Judate views are internal inlet or outlet view of the pelvis. Go for judate views. So what do we have to look for in an X-ray of a hip dislocation? We have to look if there is any incarcerated osteochondral fragment within the joint. So if this is your joint, we have to look if there is any fractured fragment which is getting impacted. We have to look for the joint space asymmetry. We have to look for the anterior or a posterior acetabular wall, and we have to look for any indentation of the femoral head. If there is an indentation of femoral head, then it will suggest that there is a fracture. You can also go for a CT scan. CT scan is done after the fracture is dislocation is reduced. We cannot do it before the dislocation. So it helps in assessing the femoral head, and it also helps to demonstrate the presence of small intra-articular fragments. It can also help to assess the congruence of the femoral head and the acetabulum, or it can also help to look for osteochondral fractures, occult impactions, indentations, and other fractures like the fracture of the acetabulum, like we can see here, is also visible. You can also go for an MRI, but this has its limitations in the acute evaluation of the multiple injured patients. However, as an adjunct to CT, it helps to evaluate the integrity of the labrum and assess the vascularity of the femoral head. and we can also look for any ligamentous injury. Coming to the treatment. So all hip dislocations are emergencies and need to be reduced within 6 to 12 hours following injury to the following injury to prevent troublesome leg complications like a vascular necrosis of the femoral head and traumatic degeneration of the hip. Once the reduction is done, urgency is reduced, and now the diagnostic workup, CT scan, surgical intervention, if necessary, can all be done once the general condition of the patient is stabilized. So there are two methods to reduce the hip joint. One is a closed method and other is the open method. Open method is also known as surgical method. Whenever a patient comes with a dislocation, we have to always try for a closed reduction first. If closed reduction fails, then we can go for an open reduction afterwards. So there are few methods of closed reduction, of which there are 5 we will be discussing here. One is Ali's method, other is Bigelow's method. Then there can be a Bigelow's method can also be done in a reverse method, that is known as a reverse Bigelow method. It can be classical Watson-Jones method. It can also be reduced by Stinson's gravity method or Whistler's technique. So first, coming on to the Alice method. As you can see, the patient is lying supine on the table. An assistant stabilizes the pelvis by applying pressure on both the anterior superior iliac spine. This is the assistant stabilizing both the anterior superior iliac spines. Traction is applied in the line of the deformity. See, this traction is applied in the line of the deformity. The hip is gently flexed to 90 degrees, and after the traction the hip is flexed to around 90 degrees, and the hip is now gently rotated internally and externally with both continued longitudinal traction till reduction is achieved. So the patient is stabilized, traction is applied, it is flexed to 90 degrees, and internal external rotation is done, and after the hip is reduced, it is stabilized. Whenever the reduction is achieved, the person who is performing the maneuver can feel for an audible clunk, and if the clunk is there, then it signifies that the reduction is successful. Afterwards, the x-rays are done, and we can look for reduction and associated fractures if any. Now coming on to the Bigelow's method, and this also the patient is supine and assistant applies contour traction on both the anterior superior iliac spine. Surgeon applies longitudinal traction in the line of the deformity, and then the hip is gently adducted, internally rotated, and bent on the abdomen. This relaxes the Y ligament of the acetabulum and brings the femoral head near the posterior inferior aspect of the acetabulum. Then by gently adducting and externally rotating and extending the hip, the head is levered back into the acetabulum. So this technique should be done with a lot of care as it requires more force and could result in iatrogenic soft tissue damage and fractures. Then there is a reverse Bigelow's method. Here the hip is in partial flexion and abduction. He has described two methods. The traction method, here the traction is applied in the line of the deformity and the hip is adducted, internally rotated and extended. He also described the lifting method. Here a flexed thigh is lifted with a sudden jerk. However, this method is not successful in pubic dislocation. Then we have the classical Watson-Jones method. So this technique is useful in both anterior and posterior dislocation of the hip joint. Irrespective of the type of the dislocation, the limb is first brought to neutral position. In this position, the head of the femur lies posterior to the acetabulum, even in anterior dislocation. Now with an assistant steadying the pelvis at the anterior superior iliac spine, the head of the femur is reduced into the acetabulum by applying a longitudinal traction in the long axis of the femur. It is simple and effective when compared to the Bigelow's method. In Stinson's gravity method, we utilize the gravitational force of Earth to reduce the joint. It is also described in shoulder joint and in hip joint. This is actually the reverse of the Alice method. In this the patient is not supine. The patient is prone at the edge of the table. Patient is brought to the edge of the table and assistant stabilizes the pelvis by applying downward pressure over the sacrum. The pressure is not applied to the anterior superior leg spine but over the posterior superior leg spine near the sacrum. The affected hip and knees are flexed to 90 degrees and downward pressure is applied on the flexed knee. Here the pressure is being applied. And to facilitate reduction, gentle rotations, both internal and external, are done. Coming to the Whistler's technique, in this the patient lies supine on the table. Unaffected leg is flexed with an assistant stabilizing the leg. And the assistant can also help stabilize the pelvis at the anterior superior leg spine. Provider's other hand grasps the lower leg of the affected leg, usually around the ankle at this part. The dislocated hip should be flexed to 90 degrees. The provider's forearm is the fulcrum. This part is act as a fulcrum. And the affected lower leg is the lever. This part is the lever. When pulling down on the lower leg, it flexes the knee, thus pulling traction along the femur. Coming to the post-reduction protocol, first, after the reduction is achieved, we have to get a radiographic verification. That is, both anteroposterior and lateral views of the affected hip and pelvis. Anteroposterior views should be taken. The X-ray has to be carefully evaluated for the concentric reduction by looking for the supple widening of the joint space. If there are any significant acetabular fractures, Jude views are recommended. So for evaluation of the post-reduction stability, after the radiographic verification of the dislocation, a stability check is carried out as follows. We have to flex the hip to 90 to 95 degree in neutral abduction and adduction and rotation. A strong posterior force is thus applied. If there is any evidence of subluxation, additional diagnostic studies are required and surgical exploration or traction may be required at a later date. You can also go for a post-reduction CT evaluation, which is very important, and the role of CT has already been discussed. Now the final staging of the hip dislocation is carried out. If the hip is stable after reduction and reduction is congruent, we have to maintain the patient comfort and apply bucks traction, and if the hip is unstable, then skeletal traction is applied through the tibia pin. And we can't allow for more than 60 degrees of flexion after the reduction. The patient is specifically advised for it. We have to mobilize the patient early. We have to tell the patient to do partial weight bearing. Complete weight bearing is avoided for 4 to 6 weeks, and repeated x-rays are allowed are taken before allowing the complete weight bearing. So if the close reduction method falls, then we can go for the operative treatment. So what are the indications of the operative treatment of hip dislocation? Indications are failed close reduction, that is irreducible hip dislocation, a failed stability test after the dislocation is reduced, if we have a big posterior lip of the acetabulum fragment fracture, if we have a bone fragment within the acetabulum, if we have a hip dislocation with femoral neck fracture, or if we have an incongruent reduction, or if we have a sciatic nerve palsy. So if there is a sciatic nerve palsy, then we have to explore the sciatic nerve and look for any damage and repair it if it is present. Any kind of neurovascular damage is a orthopedic emergency. So then coming to the techniques of open reduction. First, the approach, a posterior approach or Cocker Lagenbeck approach is mostly favored. Debridement, the joint is thoroughly irrigated to remove all pieces of bone and cartilage. In approaches, we can also go for anterior Watson-Jones or trans-trochanteric approach. The posterior approach is most favored. We can also go for a Watson-Jones or a trans-trochanteric approach. So reduction of the hip, if it is achieved after the open reduction, reposition of the fracture fragments carefully and reconstruction of the acetabulum is done. In type 2 Epstein injury, With large acetabular chunk, it can be fixed by a single cancellous screw. In type 3 acetabular Epstein injury, with several pieces of reconstruction is attempted as accurately as possible, and fixation is done with cancellous screws or small malleable plate. In severe comminution, reconstruction is done through a full thickness iliac graft or autograft. In type 4 or a type 5 fracture, fractures are fixed based on the location, and Epstein claims poor results in these cases, irrespective of the type of the treatment. So the post-operative protocol is skeletal traction of 10 to 15 laps with the hip in slight abduction and extension is applied. Within 3 to 5 days, gentle, active and passive exercises in traction are begun. Traction has to be maintained for 6 to 8 weeks. Later, protected weight bearing is allowed. So if it's a type 5 for posterior fracture dislocation, there is associated femoral head fracture and it has to be fixed separately. Coming to the complications can be injury to the sciatic nerve, a vascular necrosis of the femoral head, osteoarthritis of the hip joint, or a myositis ossificans. Myositis ossificans in layman term is just the extra bone. As you can see here, around the joint an extra bone is formed. It is most common after elbow trauma, but it can happen near hip joint also. It is seen commonly in posterior dislocation with head injury and is unknown in simple posterior dislocations. It may be seen after reduction also. It can be prevented by avoiding repeated manipulations, early mobilization, and by immobilizing for 6 weeks in hip spica. There can be post-traumatic arthritis. In arthritis C, in this is normal joint and there is joint space is normal and the acetabular lip and the femoral head are perfectly congruent, but in a osteoarthritis the joint space is reduced or obliterated, there are bony spurs and the joint line is not congruent. So it can occur with or without a vascular necrosis, may be unavoidable in cases with severe cartilaginous injury. Incidence increases with associated femoral head or acetabulum fractures. Efforts to minimize osteoarthritis are best directed at achieving anatomic reduction of injury and preventing abrasive wear between articular cartilage and sharp bone edges. A vascular necrosis of the hip joint, in this the blood supply, that is the cervical branches, which we have seen in the second or third slide, are damaged. So the blood supply to the femoral head is reduced, and as such this ligamentum teres is not contributing much to the blood supply. There is death of the bone of the head of the femur, and we can see this whitish part. Those are the necrotic fragments. So for head of the femur, major blood supply enters from the capsule and to a lesser extent through the ligamentum teres. If both these sources are damaged, it gradually leads to a vascular necrosis followed by osteoarthritis of the hip joint. Its incidence is about 10%. There can be a sciatic nerve injury. It is an emergency if it happens. Incidence of this injury is 10 to 13%. It is 3 times more common in fracture dislocation than simple dislocation. Usually it is a neuropraxia and the peroneal division is commonly affected, which results in a foot drop. It may be due to stretch of the nerve or may be due to impalement between the fracture fragments. If it is associated with acetabular fracture, the nerve should be explored. Its prognosis is variable and results in foot drop. This is more common in a posterior hip dislocation. If it's a anterior hip dislocation, then the femoral nerve and vessels are more commonly involved. So this is the last slide of the hip dislocation. Just for revision, there are 3 types of dislocation: posterior, anterior and central. Most common is the posterior hip dislocation. Second is anterior hip dislocation, and third is, which is most rare, is central dislocation. Mechanism of injury in posterior hip dislocation is a dashboard injury with knee flexed in neutral adduction or slight abduction. In anterior dislocation can also occur dashboard injury with thigh abducted, fall from height or blow to the back in squatted position. Central dislocation occurs due to direct blow over the trochanter or common in patients with epilepsy or convulsions. Classifications are the Thomas and Einstein classification or Judith classification and the clinical features. Now let us knee dislocations. So first, coming to the epidemiology of the knee dislocations. Incidences of knee dislocation have historically been reported at less than 0.02 of all musculoskeletal injuries. It is less than 0.2% of all orthopedic injuries, usually not reported as there is spontaneous reduction. 14 to 44% associated with multiple trauma, 5% can be bilateral, and more commonly occurs in males. So males are 2.5 times more affected than the females. The number is most likely an underestimate caused by spontaneous reduction and misdiagnosis. Knee dislocation have in recent years become increasingly recognized because of the advances in imaging modalities and a better understanding of the dynamic nature of the knee stability through three major ligamental structures and the joint capsule. So mechanism of injury can be a high velocity trauma, that is a motor vehicle accident, or a sports injury, or simple fall. Coming to the clinical features, the patient will present with severe pain over the knee joint. There can be a deformity, as we can see in the picture attached, or there can be inability to move the knee joint, and we have to look for neurovascular injury. So the most common structure that can be affected is the popliteal artery. So we have to look for the pulse over the dorsalis pedis to look for any vascular compartment injury, or there can be a tibial nerve or common peroneal nerve injury also. So coming to the classification systems, so there were some few old classification systems, of which I have taken three. Those are Kennedy, McCoy, and Palmer. So Kennedy's classification was based on the direction of the tibial dislocation as related to the femur. So it can be anterior, posterior, medial, lateral, or rotatory. But there were few drawbacks, like it is difficult to identify direction of dislocation in spontaneously reduced knees, and its utility is very limited because direction of dislocation is a not reliable predictor of injured structures. Other classification is by McCoy. So it is based on energy imparted at the time of the injury. So it can be either high velocity injury, low velocity injury, or ultra low velocity injury. So there are few drawbacks, like it requires detailed history and patients who are not obtended or not comatose. Its utility is like higher energy mechanisms associated with increased incidence of vascular and soft tissue compromise. Third was given by Palmer. So it is based on period of time from which injury happens to the period of management. So it can be either acute or chronic. So its drawback is 3 weeks is a division point between acute and chronic. So if it's within patient presents within 3 weeks, then it is considered acute, or if it presents after 3 weeks, then it becomes chronic. So its utility is in the management recommendations based on injury acuity. Other classification system is Schenck classification, and it is based on associated injuries along with the knee dislocation. So there are 5 grades, and grade 3 is divided into 2 types, M for medial and L for lateral. So in grade 1, there is only one cruciate ligament injured, that is either the anterior cruciate ligament or posterior cruciate ligament with collateral ligament injury. In type 2, either the ACL, that is anterior cruciate ligament, or a posterior cruciate ligament is injured and collaterals are not injured. In type 3M, either the anterior cruciate, posterior cruciate, or medial collateral or lateral collateral ligament is injured along with posterior lateral corner injury, and lateral collateral ligament and posterior lateral corner are intact. In type 3L, the medial collateral ligament is intact. In type 4, it's a global injury, and in type 5, the injury dislocation associated with the fracture of either the lower end of the femur or upper end of the tibia or the patella. Coming to Moore's classification, it is based on associated like dislocation present with a fracture. In type 1, there is split fracture through medial or lateral plateau of the tibia. In type 2, there is complete fracture separating the entire medial lateral plateau of the tibia. In type 3, there is just a rim avulsion fracture of the tibia. In type 4, there is a rim compression fracture of the tibia. And in type 5, there are 4-part fractures. Coming to investigations. So whenever the patient presents in the casualty or to the OPD, we have to always look for a neurovascular compromise. That is, if the popliteal vessels is damaged or not. So if the dorsalis pedis pulse is present, there are standard views of knees which are obtained, that is anterior posterior and lateral views of the knee joint. The timing enables the clinician to confirm adequate reduction, evaluate for any fracture, and assess overall knee alignment that may suggest a grossly unstable knee. Associated fracture has a reported incidence ranging from 10 to 20%. These fractures are often in location where the injured ligaments originate or insert. Femoral head fractures, tibial spine, and lateral tibial condyle fracture, that is the second fracture avulsions, are common. These fractures are often treated by ligament reconstruction, but occasionally, if the fragments are large enough, involve internal fixation of the fracture fragments. We can also go for a magnetic resonance imaging, which is not done immediately, but it is done after reducing the knee to look for any ligamentous injury. In the first image here, the anterior cruciate ligament is damaged. In this second image, both the anterior cruciate ligament, posterior cruciate ligament at the femoral origin are damaged, and in this, the posterior cruciate ligament is damaged. Lower limb angiogram is a very important investigation if we suspect any vascular injury. So this is a CT angiogram, this is an MR angiogram. This is the clinical picture showing bluish discoloration of the foot. So if we suspect any injury to the popliteal vessel, an angiogram is a must to look for any vascular injury. Coming to the treatment part, any joint dislocation in orthopedics is an emergency. So immediate reduction with gentle traction is attempted. If the reduction is achieved, knee is splinted in 20 to 30 degrees flexion. What are the indications for surgery? If it's a irreducible dislocation, if it's associated with open fracture, which is also known as a compound injury, or if it's associated with vascular injury. What are the complications that can occur after knee dislocation? It can be a vascular injury to the popliteal vessels, can be neurological injury to the tibial or the peroneal component of the sciatic nerve, or it can be knee stiffness due to injury to the fractures of the tibia or femur, or to any ligamental injury. It can also lead to an instability of the knee joint, or there can be a compartment syndrome. Compartment syndrome is an emergency which has to be treated by facial decompression.